Bismillahirrahmanirrahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. We started this lecture last time, that's management intricacies in intensive care unit. That way, how we manage our patients in intensive care unit in general, not specifically disease-wise. Now, what is the intensive care unit? It is a place where seriously ill, suffering more than one organ disease are admitted and treated. According to the standard, any patient who is admitted in the hospital, so it is divided into different levels. 0 level patients, level 1, level 2, level 3, and then level 4. 0 level is any patient who is admitted for example, for some operation and does not have any comorbidity, and they are looked after in the ward, and their hemodynamics and other things are monitored as per routine, 6 hourly or 8 hourly. Now, if the patient is suffering, having some comorbidity, but that's controlled, that's called level 2. And this monitoring which is done, blood pressure, pulse, temperature, so they are done quite frequently, 4 to 6 hourly, and that's called level 2. That's also kept in the hospital. That's called level 1. That's also kept in the ward. So 0 level and level 1, they are kept in the ward or in the room, and they require ordinary nursing care. So any patient who has got a comorbidity which needs to be stabilized and have suffering from one organ disease, for example, the patient is diabetic or patient is hypertensive, either it is a diabetic, the diabetes needs to be controlled. So that is HDU patient, high dependency unit. If they suffer from more than one organ disease, then it becomes level 3 patient, that is intensive care unit patient. It's one of the exception to this is patient who needs respiratory support. Even if it is one organ support is needed, one organ support, so that's level 3 patient. And the level 4 is specialized intensive care unit, like neurosurgical intensive care unit, cardiothoracic intensive care unit, post bypass. So that how we divide it: 0 level, level 1, level 2, level 3, and level 4. So in intensive care unit, you have got intensive care unit for adult, intensive care unit for the children, and intensive care unit for the neonates. And intensive care for adult, same ICU, and for pediatrics we call PICU, and for neonates we call NICU. So it's only the age difference. Now, objective of intensive care unit, when the patient is admitted to the hospital, to the intensive care unit, we want to normalize the cell physiology. The simple word, we normalize the cell physiology. What do you mean by normalizing the cell physiology? I'll explain a little bit later. But it means we want to normalize the hydration of the cell. Normalization of hydration of cell depends on the water and electrolyte balance. And we can bring, after water and electrolyte balance, we have to bring the patient into acid-base balance. After bringing the patient into water balance, electrolyte balance, acid balance, then we give nutrition to, we bring the patient into nutritional balance. They go in the same sequence. We cannot give nutrition to the patient who is not normalized electrolyte and acid-base balance, because the nutrition will not reach to its target, which is mitochondria. So it will be all wasted, or it will have some metabolic problem also. So our objective is to normalize the cell physiology. Now, design of ICU, which I mentioned very in much detail last time, there should be one entry, one exit to ICU. So everybody should not be entering from different routes. It should be centrally located in the hospital. And minimum floor space should be about 200 square feet, because a lot of equipment around it, ventilators and other things also, and it should be mobilized. The carer should be going around and around the patient and should have enough space around the bed. Now, Bed strength is, in general, principle is for every 100 bed of general hospital, we require one intensive care bed. And then there are specialized, and we specialized unit beds also. Now, physical design is, there is a reception area where there is a waiting room, reception foyer, counseling room, and overnight relative room also. So I mentioned in details why we need these things. Then there should be patient area. Patient area should be multi-bed ward. As we have got in our intensive care unit, there are multiple beds are lying there. And then there is a procedure room. There should be isolation rooms. Have you got those glass rooms? And there should be central nursing station. But there should not be central monitoring unit there. Because when intensive care, we call it intensive care, one nurse, one bed. Right? For every bed, there should be one nurse. So if we put a central nursing, this monitoring unit, they will be sitting on the monitoring unit. They will not be sitting with the bed, with the patient. So, but there is additional central monitor lying in the tea room also. When they are taking tea or having their lunch, so they can look at their patient also. But in coronary care unit, there should be central monitor also. Now, there should be storage and utility areas, like for equipment area, disposable areas, linen and stationery area, fluids and vascular catheter area, clean and dirty utility areas. So it becomes a very big unit. So there should be provision for all these things. Then monitoring, bedside and central monitors, invasive devices, cardiac output computer, EEG monitor, blood glucose monitors. In radiology, should have X-ray, image intensifier, X-ray viewer also. Almost we have got all these things in our intensive care unit. Now, respiratory therapy. For respiratory therapy, we should have ventilators. With the ventilators, there should be humidifiers also. There should be oxygen therapy devices, intubation trolley, airway devices, self-inflating resuscitator, which we call which is one of the self-resuscitating resuscitators is called EMBU. EMBU is the company's, and it's a misnomer for everything they call EMBU bag. So EMBU is the company. So it is self-inflating because when you press it, it comes back to its original shape automatically. Then fiber optic bronchoscope, and there should be a provision of one anesthesia machine also in intensive care unit in case you have to anesthetize the patient. Cardiovascularly, you should have a CPR trolley, defibrillators, temporary pacemaker, intra-aortic balloon pump, infusion pumps, and syringe pumps. Dialytic therapy, dialysis. There should be hemodialysis machine, hemofiltration machine, hemodiafiltration machine, then peritoneal dialysis equipment. All these things should be at least on one bed of the intensive care unit. Hemofiltration should be not a hemodialysis. Hemodialysis is a separate unit. Hemofiltration is on 24-hour basis. We do the dialysis. Laboratory should have a blood gas analyzer, thromboelastograph, microscope, osmometer, in addition to general laboratory tests. Hardware should be dressing trolley, drip stands, heating and cooling blankets, pressure mattresses, and sterilizing equipment. It's almost one whole hospital in intensive care unit. Medically, there should be one medical director of the ICU, should be intensivist, junior doctor, nursing staff. Nursing staff should have a manager, should have a nurse specialist, should have a nurse educator, should have critical care nurse training, if it is a proper intensive care unit. As we have got a proper intensive care unit, but we don't have these things here because we are in a private hospital, because all the nurses run to the government hospitals. Then allied health services should be there, like physiotherapist, pharmacist, dietitian, respiratory therapist, technicians to look after the equipment, social workers, secretary, ward clerk, then sports staff, ward boy and jamadar, the sweeper and ward boys. these are sports staff. So all they should be available. They should be specifically related to ICU. Staff areas. Now they have to look after the staff also. There should be a rest room because they get tired very quickly. It's a very hard work to do the nursing of the intensive care patient. So it should not be hardly working, it should be hard work. So most of the time we have got hardly working. Should be changing room, toilets, offices, doctors on call room, seminar conference room, then cleaners room. They can more or less we have got almost provision of almost all the things. Economics of ICU. For humanity, it's very essential part of the hospital. So every hospital, whether it is a district headquarter hospital or it is a Tehsil headquarter hospital, should have intensive care beds. It's very essential. So that's why I used to go to all the district headquarter hospital, and this is a Tehsil headquarter when I came in 1980 back from England, and I used to tell them, open the unit to deliver lectures there every Sunday. But nobody knew about the name of ICU that time. Our initial ICU is the first ICU in the whole country. When our hospital came, and then the Sheikh Zayed hospital, they came later on. Now it uses 8% of the hospital budget if it is a government setup. But in a private setup, it's paid by the patients. There are fixed costs that's in the form of salaries. Then variable costs, depending on the admission, depending on the type of the patient, and depending on the services we are rendering to the patient. Levels of ICU. Then ICU has got its own levels also. District hospital should have a closed nursing, ECG monitoring, provision for 24 hours ventilation. At least they should be there. Level 2, general hospital should have ECG, prolonged ventilation, should have access to radiology, pathology, and physiotherapy. It's a little bit advanced than that. Then level 3 is the tertiary hospital, as we got in Ishtar Hospital. They should be referral unit, specialist intensivists should be there, critical care nurses should be there. There should be support of complex investigations also, in addition to basic design and everything. So we treat like this. At least in the Tehsil headquarter hospital, there should be a room there, and there should be a provision of ventilation for a short period, and at least there should be ECG monitor. Who should be in charge? The answer is intensivist. Who is the intensivist? Anesthetist plus training in ICU. That's the first priority. Physician and surgeon plus anesthesia training plus training in ICU plus specialization in ICU. Then they can become intensivist. Because as an anesthetist, our training, our fellowship exam and fellowship training includes intensive care training itself. And we read advanced physiology and advanced pharmacology also, and advanced technology also. Why the anesthetist should be in charge? Our postgraduate training is based on advanced physiology, advanced pharmacology, and advanced technology. We are accustomed to dealing with the different consultants. Sometimes we are dealing with the orthopedic surgeon, sometimes with general surgeon, sometimes with gastroenterologist. So we are used to it. So we are the best people who can liaison with the different specialists. We are used to decide conflicts. Whenever there is an argument, it is the anesthetist who decides. Used to concentrate on individuals. Whether we are in theater or we are in the pain clinic or in ICU, we are concentrating on one patient. But the surgeon and physician, they are concentrating on a whole ward or something like this. So that's why, anesthetist should be the intensivist. No outpatient commitments. We don't have any commitment to the outpatient, so we are free also. Used to rapid decision making and act upon it. because anesthetists should have a very quick reflexes, very quick thinking. They should be able to decide spontaneously on the bedside, as we do in theater also. We concentrate on individuals and we decide. If the emergency arises, we decide very quickly. Why we require so much monitoring? Because there is a variable response, physiological response to different seriousness of disease. There is multiple organ involvement, and there is a continuous pharmacotherapy to these patients. There is close observation needs precision. For precision, you need monitoring. So that's why there is sophisticated monitoring system around the patient or on every bed. What do we monitor? We monitor the dysfunctions of different systems, like dysfunction of cardiovascular system, dysfunction of respiratory system, dysfunction of renal system, dysfunction of brain, and dysfunction of gastrointestinal tract, and then hemoptysis. All these things, they require to be monitored by sophisticated monitors. Now, normalization of cell, that's what we do in the ICU. What does it mean? We should bring the cell into water balance, then electrolyte balance, then acid-base balance, then nutritional balance. They go in the same sequence. We cannot bring the body into nutritional balance unless the body is in water, electrolyte, and acid-base balance. So it should be dealt with it accordingly. Systemic diseases upset the above balances. We support systems till the cell is normalized. Now we start taking the steps to normalize the cell. At the same time, while the cell being normalized, we support the systems of the body. There are 6 systems in the body, 2 primary systems, respiratory and cardiovascular system, 4 dependent systems, brain, liver, gut, and kidney. We don't have anything to do with the bone. We don't have anything to do with the muscles, except a few patients who are suffering from some muscle disease. On cardiovascular hemodynamics, we look at the cardiac output. Normal cardiac output, everything normal should be known first. Cardiac output is around about 5 liters per minute. Cardiac index is, if you divide by the surface area of the body, that's 3.2 liters per minute per square meter. आपका एरिया कितना है हर एक का? How much is your surface area? तो पता है किसी को अपने आप को नहीं पता है, दूसरों को क्या पता लगाना है? How much is your surface area? In a normal person with a normal height should be 1.7 square meter. 1.7 square meter. So if you divide the cardiac output by its surface area, that becomes cardiac index. Then pulmonary capillary wedge pressure is about 5 to 10 millimeter of mercury. Central venous pressure is 6 to 12 millimeter of mercury. Blood pressure normal is 120 by 80. And stroke index is cardiac index divided by rate, that is 45 mils per beat. Then stroke volume is cardiac output divided by rate. If you divide the cardiac index by rate, it becomes stroke index. Then if you divide the cardiac output by its rate, then it becomes stroke volume. Now there are different parameters also. We did last time also. Respiratory system mechanics, total lung capacity. You should know how much it should be. Then functional residual capacity. Then inspiratory capacity. Then expiratory reserve volume. Then residual volume. Then tidal volume. Then minute ventilation. Then alveolar ventilation. Dead space. And peak inspiratory pressure. Then if you go to pressure, peak inspiratory pressure, then you should know the plateau pressure also when you are ventilating a patient. So all these things are normal, which you should know before you detect the abnormality. Now, commonly admitted patients to the hospital are acute respiratory failure, acute lung injury, ARDS, multiple organ dysfunction syndrome, head injury, metabolic diseases, multiple trauma, eclampsia, preeclampsia, GB syndrome, poisoning, and tetanus. So this type of the patients usually are admitted into ICU in our country. It varies from country to country also. Now oxygen is very important. You should know in depth the oxygenation of a patient, oxygenation status. Because when you say about oxygenation status, you start from the nose or from the mouth where the air is going in. How much is the oxygen in that and what is the pressure of that oxygen? When it reaches to alveoli, what is the pressure of oxygen in the alveoli? When it reaches to, what is the difference between the partial pressure of oxygen in the alveoli and partial pressure of oxygen in the arterial blood? Then amount of oxygen which is taking it to the cell or to the tissues, that's called delivery of oxygen, total amount of oxygen which is taking it. Then out of that, then oxygen is extracted by the cell and that's called VO2. Then we look at the lactate, whether the oxygen which has been extracted is being used or not, to see that. So if, because the metabolism is going on all the time, if the oxygen is present, it is called aerobic metabolism. If oxygen is not present, it is called anaerobic metabolism. If there is anaerobic metabolism and oxygen is not being used, then the lactate will be produced. That will tell you, and then you have to find out what is the cause of raised lactate, right? So if you assess the oxygenation status that way, then we say now you have assessed the oxygenation status. Only knowing the saturation and only knowing the partial pressure of oxygen does not tell you 100% about the oxygenation status. It only tells you that oxygen is passing to the lung and going into the blood. But our target is the oxygen should reach to the cell where it is needed. So there are few terminology one should know. Then CaO2 is oxygen content, arterial oxygen content. Normally it's 20 cc per deciliter of blood. Then CVO2, oxygen content of the venous blood, is about 16 cc per deciliter. Then PaO2, alveolar partial pressure of oxygen, and it's about 100 to 108. And then P small AO2 is about 100. The difference is A gradient. Then we make the ratio of inspired oxygen concentration to the partial pressure of oxygen in the blood. It's usually 1:5 ratio. So that's called oxygen index. Then we theoretically calculate the oxygen content. Then we calculate the shunt, the blood which is coming and passing through the lung and is not coming in contact with the gases or air which has gone into the lung, that is called shunted blood. So there is a specific equation to measure the shunt. CCO2 minus CaO2 divided by CCO2 minus CVO2. Normally there is a 5 to 8% of shunting because of few known physiological reasons. Now, if there is a saturation of venous blood is very important, which we hardly do, and nobody concentrates on this. We are always looking at the saturation of arterial blood, but if you look at the saturation of venous blood, that gives you a lot of information. It could be due to hypoxemia, it could be due to increased metabolic rate, it could be due to low cardiac output, it could be due to anemia. There are 4 causes of reduction of SVO2, and accordingly we correct it. If there is hypoxemia, try to find out what is the cause of hypoxemia, how we can treat it. Then if it is increased metabolic rate, why not to give more oxygen to the patient? It means you are giving inadequate amount of oxygen for that high metabolic rate. Then if it is low cardiac output, try to increase the cardiac output and find out what is the cause of reduction in cardiac output. Then if the person is anemic, although saturation is being given you 100%, but the total amount of oxygen which is carried by the hemoglobin. Bulk of oxygen is carried by hemoglobin. Lower the level of hemoglobin, the less will be carried out, less will be DO2, less will be delivered to the tissues. So then you have to analyze all these 4 causes. Now the important gas equations or gas exchange equations are, one is a dead space equation, VD over VT. Then shunt fraction, QS over QT. Then AA gradient. Then AA ratio. Then partial pressure of oxygen, and FiO2 ratio also. It should be greater than 300, normal is 500. If the ratio is between 300 and 500, we take it as a normal. If it becomes less than 300 but greater than 200, we label it as acute lung injury. If it is less than 200, this ratio, then we say patient has gone into ARDS. So accordingly, we take up the step of the management. Now, acute lung injury to ARDS. So by definition, it is a refractory hypoxemia plus non-cardiogenic pulmonary edema. If you pathophysiological definition of ARDS, it is a refractory hypoxemia plus non-cardiogenic pulmonary edema. Management, we have discussed in detail, at least 2 lectures I took on these. Then control the parent problem. So very important to treat the cause, control the parent problem. Then we do the progressive dehydration. Progressive dehydration means the lung is wet. Take them into dehydration while keeping the hemodynamics normal. To take the person into negative balance but keep the hemodynamics normal, because if the hemodynamics is normal, it will carry out the oxygen nutrition to the tissues. If the hemodynamics is not normal, then the required amount of oxygen and nutrition will not reach to the cell. So that's called progressive dehydration. Taking the patient into negative progressively, but while keeping the hemodynamics normal, this is called progressive dehydration. Only 2 strong indications by doing progressive dehydration. One is ARDS, other is ECLAMPSIA, pre-ECLAMPSIA. There also we do progressive dehydration. Then optimize the distension of the alveoli. Keep the alveoli open. If the person is in ARDS, optimize the distension of alveoli. How can we do it? Optimize the functional residual capacity, number 1. Number 2, decrease the progressive atelectasis by choosing the different modes of ventilation. Now, what are the ventilatory modes for ARDS? It is definitely they are put on pressure controlled mechanical ventilation. Second is pressure controlled mechanical ventilation plus inverse ratio ventilation. Third is pressure controlled mechanical ventilation plus PEEP. Fourth is pressure controlled mechanical ventilation plus pressure limited plus induced hypercapnia. There are different modes. We play with it according to individual needs of the lung, according to the damage of the lung. Then there are adjuvant sports, position changing, putting supine, lateral position and prone position. So they, in addition to ventilating, so it gives a very good result for keeping the lung open. Then you concentrate on the pulmonary edema. Then there are sophisticated ventilation means, DLV, differential lung ventilation. Both the lungs are ventilated at a different tidal volume and pressure load. Or even you can ventilate individual lobes also. I have seen the patient put on 5 ventilators, one patient, because there are 3 lobes on the right side, 2 lobes on this side. Every lobe, if there is a patient is involved, seriously ill, so every lobe has got a different ventilation perfusion ratio. According to ventilation perfusion ratio, every portion of the lung has got different time constant. According to time constant, we put on different modes, on a different tidal volume and respiratory rate and the pressure. So it's because if we control the both lungs at the same time, so some part of the lung which has got low resistance, it will be hyperventilated. And those who have got high resistance, they will not be ventilated. So it's according to the ventilation perfusion ratio, according to the time constant, we choose different modes for individual, both lungs separately or individual lobes separately. That's called differential lung ventilation. Another way of ventilating is high frequency ventilation at a fast rate with low tidal volume. High frequency positive pressure ventilation, high frequency oscillation, high frequency jet ventilation. There are 3 types of high frequency ventilation. Then we can use ECMO also, extracorporeal membrane oxygenator. Or we can use low frequency positive pressure ventilation plus extracorporeal carbon dioxide remover. So all these are different ways of treating the patient who is suffering from ARDS. Then there is novel therapeutic approaches, use of nitric oxide. This is a separate topic. And then prostaglandin system inhibitors, free radical scavengers, then use of surfactant, then immunotherapy. So everything has got a separate topic to be considered. Nitric oxide, I've written one chapter in detail in my book. Nitric oxide is being used in the intensive care units. Renal, to summarize the renal function, you should be able to differentiate whether it is a prerenal problem or renal problem or postrenal problem. If it is a prerenal problem, it is our job to normalize the GFR. If it is a renal problem, it is the job of nephrologist. If it is a postrenal problem, it is the job of urologist. So we should be at least able to differentiate between them, and every patient who is in intensive care unit, we should measure the eGFR. So it's very easy to do it, and accordingly we should take up the step. Then as far as the brain is concerned, we monitor the conscious level. One of the way of measuring the conscious level is Glasgow Coma Scale. We have on our chart, and every morning the nurses, in every shift, the nurses, they calculate what is the Glasgow Coma Scale. So the point about this is, if the patient is sedated or patient is on a ventilator, you cannot assess the Glasgow Coma Scale. It is a person who is not on sedation, or a person who is not on a ventilator, then Glasgow Coma Scale can give you the exact conscious level. Now there are a few shock syndromes we have to deal with the patient. The parameters which we look at, the pulmonary capillary wedge pressure or CVP, cardiac output, and systemic vascular resistance. Now, if the person is hypovolemic, the pulmonary capillary wedge pressure will be low, cardiac output will be low, systemic vascular resistance will be increased. You should be able to, as a medical officer, you should be able to differentiate what sort of problem is this patient. If it is a cardiogenic syndrome, then pulmonary capillary wedge pressure will be increased, cardiac output will be decreased, SVR will be increased. Then accordingly you take up the step. ये किसका बज रहा है? If it is vasogenic or septic, pulmonary capillary wedge pressure should be low, cardiac output will be increased, but systemic vascular resistance will be reduced also. Accordingly, you take the step. If the pulmonary capillary wedge pressure is low, you give them fluid, right? That is the first thing. If the cardiac output is low plus normal SVR, you use dobutamine. Or if the cardiac output is low and decrease SVR, then you use dopamine. If the SVR is reduced, you use vasoconstrictors only, or you can use alpha and beta stimulant at the same time. You can have that effect from dopamine also. So if you only want to use alpha blocker, alpha stimulant, you can use norepinephrine or noradrenaline. This is just to give you the hint. Now, anemia is very important because hemoglobin is the thing. Important thing is that oxygen delivery or DO2 depends on the hemoglobin level. What are the function of hemoglobin? Why we are worried about hemoglobin? One thing is this: oxygen carrying capacity, because the bulk of oxygen is carried by the hemoglobin. Second, what is the second function of hemoglobin? The viscosity of blood depends on the hemoglobin, because blood pressure is nothing but cardiac output into peripheral resistance, and cardiac output is nothing but stroke volume into heart rate. Peripheral resistance is nothing, it is the caliber of the blood vessel and the viscosity of blood. Now, if a person is anemic, doesn't matter artificially, you can use an norepinephrine or you give bolus of vasoconstrictor, but it comes back again. That indicates that there is anemia. And treat the anemia, increase the viscosity of blood. So hemoglobin, second contribution is towards the viscosity. The third role is, it has got important role in acid-base balance. So if you look at the chloride shift, how the carbon dioxide is carried, then you will realize what is the role of hemoglobin. Yeah. Okay, then DO2 is nothing but oxygen content into cardiac output. Absence of hemoglobin. If you completely remove the hemoglobin from the blood, why the nature has put the hemoglobin there? If you got only plasma, there's no hemoglobin, you need 85 liters of cardiac output to have the proper required amount of oxygen delivered to the tissues. 85 liters. So nature has reduced from 85 liter to 5 liters with the help of hemoglobin to normalize the oxygen delivery to the tissues. So बहुत सारी चीज़ें ऐसे ही होती हैं, जैसे हम एनेस्थीसिया के सर्किट की बात करते हैं. Absence of hemoglobin requires at least 85 liters of cardiac output. Natural compensation. If there is anemia, what are the natural compensations? Decreased oxygen content will increase the 2,3-DPG, 2,3-diphosphoglycerate. It is related to oxygen dissociation curve. Higher the level of oxygen 2,3-DPG, the oxygen dissociation curve will be shifted towards the right. If 2,3-DPG level is less, it is shifted to the left. It means it's association and dissociation of oxygen to the hemoglobin depends on one of this factor, which is 2,3-DPG. There are three factors on this oxygen dissociation curve depends. One is pH, acidity or alkalinity. Second is temperature. And third is level of 2,3-DPG. If you look at the Embden-Merhoff pathway of carbohydrate metabolism, you will know from where the 2,3-DPG is produced and how it is metabolized. Right? It's a beautiful diagram in Ganong. आप देखें, उसको कभी भूल ही नहीं सकते. उसी से आपको पता लग जाता है एसिडोसिस में क्या हो जाता है, एल्कोलोसिस में क्या हो जाता है. उसमें उसको अपना कंसेप्ट बनाएं. इट्स अ ब्यूटीफुल वे एंड नेचर ने ऐसा फर्स्ट क्लास कंपनसेटरी मैकेनिज्म रखे हुए हैं, तो हम उस पर कंसंट्रेट नहीं करते. नाउ लेस देन 10 ग्राम ऑफ हीमोग्लोबिन. If the hemoglobin level goes less than 10 gram, then the cardiac output is increased. Nature tries to compensate the oxygen delivery to the tissue by increasing its cardiac output. Right? Then hematocrit. If there is a reduced hematocrit, it will reduce the viscosity. When viscosity is reduced, it will increase the cardiac output and it will drop the blood pressure also. So it means the blood flow will be increased more to compensate. Now, reduction in hemoglobin will increase the erythropoiesis also. The reduction in hemoglobin will increase the organ perfusion by increasing the heart rate and by increasing the cardiac output. So hemoglobin is very important. We should know the normal function of hemoglobin and we should know what are the compensating mechanisms if the person becomes anemic. How does the nature try to compensate it? Then monitoring. Oxygenation in DO2. For this we require pulse oximetry. Anemia is symptomatic. Mainly it affects the blood pressure because of reduction in viscosity. Heart plus lung plus renal problem there, we should always put the central venous catheter in, measure the central venous pressure. These are essential things which I am mentioning about anemia and ICU. Now, congestive heart failure plus lung plus renal disease plus massive blood loss, pulmonary capillary wedge pressure should measure the blood volume, should measure the cardiac output, we should look at the delivery of oxygen. It's very easy to do it if you sit down and calculate it. SpO2 is a continuous guide to the DO2. If you look at the SpO2, venous blood saturation, so it is a guide to the DO2. SpO2 greater than 75% is ideal. SpO2 less than 75% plus tissue oxygenation inadequate. So blood transfusion should be given to these patients if hemoglobin has gone down. SpO2 greater than 75, it means 85 to 90% plus good tissue perfusion. That reduces the consumption. That means that reduces the VO2. इन चीज़ों को मतलब सोचें, फिर आपको ये अंडरस्टैंड होगी. मैं आई कैन गिव यू द लेक्चर्स, फोटोकॉपी मुझसे ले लें, मैं दूंगा उसको. एक एक आइटम को आप गौर करें कि इसका मकसद क्या है. राइट, SpO2 ग्रेटर दैन 75, 85 to 90% plus poor tissue provision, that indicates there is a reduced DO2. So that will reduce the DO2 also. That also indicates a reduction in DO2. So all these things need to be analyze yourself. Until you do yourself, you cannot understand properly, you cannot retain it. Now, fluid therapy, when we plan in intensive care units, we look at, there are three compartments. You have got a capillary or the vessel, then outside the vessel is interstitial compartment, outside the interstitial compartment is the cell. Our objective of fluid therapy is always you fill the body from inside out. Inside is the vessel. Fill the vessel first. Then outside to the vessel is the interstitial compartment. Fill the interstitial compartments then. Then last you fill the cell. Because until unless the vessel is full, it cannot take the oxygen and nutrition to the cell. So that needs to be filled first. So in principle we always say, whenever you plan your fluid therapy, you plan in such a way you fill the body from inside out. Whichever is a compartment is empty, you fill that, but always keep an eye on the vessel first, then interstitial compartment, then the intercellular compartment. Now, if you look at this, they are between vessel and this, there is a capillary endothelium. Capillary endothelium has got pores in it. Water can easily pass on the both direction, but there are forces which are controlling it. First force is hydrostatic pressure. That is a representative of blood pressure. It tries to push the water out of the vessel. Then other force is cold-head osmotic pressure. Cold-head osmotic pressure tries to keep the water in. What is cold-head osmotic pressure? Cold-head osmotic pressure is exerted by the proteins. Not by all the protein. It is the smallest molecule of protein which cannot cross a capillary endothelial pore. That is albumin. When the pore becomes bigger, like in sepsis or in a burnt patient, then albumin becomes ineffective to contribute to the cold-head osmotic pressure. Then the next protein comes into action. So these are two forces on the both sides of the capillary endothelial wall which control the movement of the water. Otherwise, water can cross very easily. Then you come to the partition between the interstitial compartment and intercellular compartment, that is a cell wall. Now water can easily pass through the cell wall, but there is a force which controls it, that is the osmolality or osmolarity. Osmolarity depends on osmotically active ions on the both sides of the cell wall. What are the osmotically active ions? Sodium, potassium, calcium, magnesium. Right? These are the positive ions. जितने पॉजिटिव आयन होंगे उतने के साथ ही उसके नेगेटिव आयन होंगे, मेल के साथ फीमेल, उससे चले उन सारे को जमा कर लें. दैट इज़ अ मेजर्ड ऑस्मोलैरिटी. आपको पता लग जाए अगर आपको इनमें सबसे ज़्यादा लेवल किसका है? सोडियम का. नॉर्मल ऑस्मोलैरिटी इज 285 to 295 मिली ऑस्मोल पर लीटर. तो आउट ऑफ 285, 140 is the sodium and 140 is the negative ion with it. It becomes 280. Out of 285 to 295, 280 is contribution by sodium. If you know only sodium, you will understand what is happening at the cell level, whether the water is staying out or going inside the cell. So that's what happens in a preeclampsia. In preeclampsia, the pregnant lady is losing proteins. And because losing protein, cold-head osmotic pressure is less. At the same time, there are pregnancy-induced hypertension also. That's increasing the hydrostatic pressure. Both they favor in the movement of the water out of the vessel into interstitial compartment. When they reach to interstitial compartment, they dilute the sodium, so osmolarity goes down. Then the water starts going inside the cell. When the water starts going inside the cell, that increases the size of the cell. Patient gets headache. And when the cell swells, then the distance between the cell wall and mitochondria increased. It means it will take longer time for the oxygen to reach from the cell wall to the mitochondria. Then the patient starts convulsing. Then the preeclampsia converted into eclampsia. If you don't treat it, the patient will die. So the same way we bring the water back into the vessel while keeping the hemodynamics normal. We induce progressive dehydration in case of the condition. It's very simple, physiological based. So that's how we look always on three compartments when you plan your fluid therapy. Always spend 5-10 minutes before you plan when you are planning your fluid therapy. Now, total body water is 60% of body water, 60% of body weight. For example, if the person is 70 kilogram, 60% of this weight is water. So 60%, 60 divided by 100, multiplied with 40, it becomes 42 liters. Out of 42 liters, 2/3 water is present inside the cell. That's 28 liters. Then 40 liters is left. Out of 40 liters, again 2/3 in the interstitial compartment. 9 liters is there. Then 1/3 is in the plasma, that is 5 liters. So this is the distribution. And those are the factors which are maintaining this ideal situation in the patient. Until unless you have got the adequate amount of in the cell, adequate amount of water in the cell, adequate amount in the interstitial compartment, adequate amount of the vessel, you cannot have adequate function of the cell, because this proportion will enhance the delivery of nutrition and oxygen to the mitochondria. If you disturb any of the compartment, it will hinder. So that will cause problem. Now there are only two types of fluid, colloid and crystalloid. Out of crystalloid, you got sodium free and sodium containing. Sodium free is 5% extra water, 10% extra water, or 25% extra water. And sodium containing, you got a plevolatime, you got Ringolect, you got a Hartmann solution, then you got 0.9% saline. And you should know, as a nurse and as a doctor also, what is the concentration of sodium in all these different fluids, because the same concentration will tell you what is the osmolality of that fluid. Okay? If you got low sodium, definitely you will choose such a fluid which has got high sodium level. If you got high sodium, you will choose such a fluid which has got low sodium level than that of plasma. Now, for example, if I give you 1 liter of 5% extra water, how much will stay in the vessel, how much will go into the interstitial compartment, and how much will go into the cell? You can mathematically calculate it. It doesn't mean that it's a hard and fast rule, but you can nearly guess which compartment is getting how much. Now, if you look at the 5% extra water, it does not have a colloid activity. It does not have a sodium, so there is no contribution to osmolality. It means its volume distribution is intravascular compartment, interstitial compartment, intercellular compartment. All 42 liters of water is water of distribution. Now, if you look at plasma has got 5 liters out of 42 liters. 5 divided by 42, you are giving 1000 mils of 5% extra water. If you calculate it, it becomes 120 mil. You have given 1 liter of 5% extra water. Out of that, only 120 mil has stayed in the vessel. If the person is hypovolemic, this solution is useless, because the bulk of water will go outside. Now, if you give saline solution, 0.9%, so first of all, we do 5% extra water. What happens to interstitial compartment? Interstitial compartment has got 9 liters of water. And out of 42 and multiply with 1000, you are giving 5% extra water, it comes out to be 333 mils. So about 333 mil of 5% extra water will stay in the interstitial compartment. The rest will go into the cell, which is about 547. Now the bulk has gone into cell. If there is intracellular dehydration, this is the best solution, 5% extra water to be given to the patient. If the patient is hypovolemic, there is no use giving 5% extra water. If there is a 1 liter of deficiency in the plasma volume, you will have to give at least 8-9 liters of 5% extra water. पानी में डबो देंगे उसको आप, पल्मोनरी एडीमा में चला जाएगा patient will die. So इसलिए to choose the right solution for the right compartment is very important, and it's very easy. It's not difficult. Just spend 5 minutes on it. Then next solution is sodium chloride, 0.9%. This is not a normal solution. This is 0.9%. Normal solution 1, which contains 1 gram equivalent in 1 liter. Physics की definition के लिहाज, it is a 0.9. It's not 1 gram. It's not a normal solution, which normally everybody says normal saline, normal saline. Then you got 5. This is sodium containing solution. Now, in the vessel and the interstitial compartment, when it goes to the cell wall, it will stop there because it will affect the osmolarity. So it means volume of distribution of 0.9% saline or the saline sodium containing solution is only 5 liters of plasma and 14 liters of interstitial compartment, total 19 liter. Now in plasma, 9 liter, this about 9 plus 5, 14 liters. Now plasma, we've got 5 liter out of 14 liter, multiplied with 1000, it comes out to be 263 mil. 263 mil of saline will stay in the vessel. Rest will go out. It's better than 5% extra water, but still it is not an ideal solution to resuscitate the hypovolemia. It's not ideal because bulk has gone out. And in the interstitial compartment, there are 14 liters, out of 14 liters into 1000 is equal to 737 will stay in the interstitial compartment. It means saline solution is ideal for interstitial compartment. It is not ideal for vessel, it is not ideal for cell. Then third solution, colloid solution. Now colloid solution has got volume of distribution of blood volume because it will not go out of vessel because there are pores, it will stop it there. So 5 divided by 5 multiplied with 1000, all 1000 will straight away stay in the vessel first. So this is the ideal solution to resuscitate the vessel. If the person is in hypovolemic shock, the first solution to be given is a colloid solution. The second choice is saline or sodium containing fluid. And there is no choice for 5% extra water. Right? So in all conditions, so our choice, otherwise thinking about it, if there is a post-operative patient, we try to give such a fluid which has got electrolyte concentration like that of plasma, near to that plasma, that is ringolactate or Hartmann solution. For head injuries, or if the person is hyponatremic, or if there is a brain insult, we give 0.9% saline because it is slightly hyperosmotic solution. It will extract the water from the cell and the cell will be dehydrated. So if you look at the Hartmann solution, the sodium level is 134. So 134 is a negative ion with it. 134 plus 134, 268. Normal osmolarity is 285, 295. It means slightly hypoosmolar. If you give this Hartmann solution or ringolactate solution to the person who has got head injury or has got brain insult, you will enhance the brain edema. So ideal solution is 0.9% saline. Right? ये याद रखें थोड़ा सा, अगर कंसल्टेंट गलती से लिख गया या कह के ऐसे बोल गया ना तो आप उनको रोक दें, कहते हैं ये तो आपको इतना नॉलेज होना चाहिए नर्सेज को भी और जूनियर डॉक्टर को उनको स्टॉप करेगा नहीं, वी कांट गिव। यहाँ पेलाबोलेट एम देते थे लोग न्यूरो फिजिशियन भी, मैंने बड़ी मुश्किल से रोका उनको, उठा के समझाया, क्वालिफाइड हाईली क्वालिफाइड पीपल दे वर गिवन पेलाबोलेट एम दे जी ब्रेन के लिए। नाउ एक्लेम्पसिया, जस्ट giving the touches, I'm doing the touches. Now we used to get a call from the labor room when I was in niche there. I used to tell them I've got 2 beds, always I kept empty for the pre-eclampsia and eclampsia patient. I said send them early, but when the patient reaches to labor room, the blood pressure is high, systolic as well as diastolic. Proteinuria is more than 5 gram, oliguria is 5 mil or less than that. Then epigastric pain, cyanosis, pulmonary edema, and the patient is convulsing. A eclamptic patient when they come. And by the time he reaches to ICU, the blood pressure has gone down to 80, urinary output is nil, convulsion, pulmonary edema, and the patient is cyanosed. We used to have a regime, this one. Put the central venous catheter in, monitor the CVP, put the urinary catheter in, put the nasogastric in, all 3 catheters in. Heavy sedation with midazolam, or that time we used to use phenobarbital also, and put the patient on ventilator, IPPV. Hemexil 500 mils per day to keep the fluid inside the vessel. Then blood 500 ml daily if the hemoglobin is less than 10 gram. Inotropes if needed, balance. We used to keep them in negative balance. We used to do progressive dehydration. Then in 7 to 10 days, we used to remove 10 to 14 liters. I have removed 27 liters. That's the maximum of one of the surgeon. He is still alive. His wife is still alive. And she was kept for 7 to 10 days on ventilator also. सूजी हुई थी जब आई ऐसे पतली होकर चली गई. So, and we kept her on ventilator. Within 3 to 4 days, we take them off the ventilator once everything starts going down. So, and I used to give mannitol also, because mannitol extracts the water from extravascular compartment to intravascular compartment, and through the kidney it's washed out. Because if you give colloid solution stop the water to go out. It does not extract the water from the extravascular compartment. To extract the water from extravascular compartment, you give them mannitol. तो mannitol बाहर से अंदर लाएगा, अंदर से फिर किडनी के जरिए बाहर फेंकेगा on proximal tubule. It acts as a diuretic, because mannitol is diuretic in the proximal tubule. The water reabsorption in the proximal tubule is 70% of GFR. It's producing more urine as compared to Lasix. Lasix is dealing with 60% of reabsorption. This is dealing with the 70% of reabsorption.